All, this is Dr. Mobeen Sayed from drbeen.com. Today we will continue our discussion with the drugs that we were looking at in Math Plus protocol. The drug that I want to talk about today is aspirin or acetyl salicylic acid. So let us start our discussion. We're gonna start from the same place where we were working yesterday with the epoprostenol or the PGI2. So let us start. I'm going to share my screen and we'll go from there. So here, if you remember yesterday when we were talking about it, we were talking about the membrane phospholipids, that are these phospholipids present in the cell membranes, and cell membranes, platelet membranes, and all of our cell membranes. There is an enzyme in there, we talked about it yesterday as well, that is called phospholipase A2. That enzyme works on the phospholipids here in the membrane of our cells and converts that into arachidonic acid. Arachidonic acid in turn is then operated upon by two types of enzymes, cyclooxygenases 1 and 2 or lipooxygenases. So what happens is when cyclooxygenases work on the arachidonic acid, they convert that into PGH2, and that then further is converted into PGI2 or prostacyclin, thromboxane A2, and then prostaglandins. On the lipooxygenase side, the final substrates are leukotrienes B4, leukotrienes C4, D4, and E4. There is F4 as well. Now, the important thing for us to remember today is that the leukotrienes are mostly able to sustain inflammatory reactions. So whenever there is a more production of leukotrienes, inflammation sustains. Secondly, leukotriene B4, for example, especially, that causes the chemotaxis for the inflammatory cells to come over to the tissue and take part in a fight. For example, neutrophils or macrophages or other inflammatory cells. So keep that in mind because I'm going to use that as we discuss about the aspirin. The main area that we are going to discuss again today is this part. This is the prostacyclin and thromboxane A2. Yesterday we discussed that prostacyclin, which was the epoprostenol, prostacyclin causes vasodilatation and it inhibits platelet aggregation. We also saw that thromboxane A2 causes vasoconstriction and causes platelet aggregation. So keeping that in mind, let us look here at the NSAIDs in general. So NSAIDs are non-steroidal anti-inflammatory drugs. And there are many drugs that are in this category. Aspirin, of course, that is what we're going to talk about today. Aspirin is part of the Math Plus protocol as well for COVID-19 hypercoagulable state. Ibuprofen is another, indomethacin, celecoxib, diclofenic acid, and then rofecoxib and more as well. And please remember that rofecoxib has been withdrawn from the market because of its side effects on cardiovascular system. Similarly, celecoxib has a box warning on it because of its side effects. So I would stay today towards the aspirin. Aspirin is also called acetyl salicylic acid, or that is the chemical name for this. And if you see here, this chart, this is again the same thing as yesterday, and I just went over that. Arachidonic acid is operated upon by COX-1 and COX-2 enzymes. These enzymes help produce PGH2, which then helps produce PGI2, thromboxane A2, and so on. So that is in contrast, which act on phospholipase A2 and then block the whole thing here. Instead of that, NSAIDs, they work and block cyclooxygenase 1 and 2. The result of that is then that these products here, prostacyclin, thromboxane A2, PGE2, and PGF2 are reduced. Now, keep this in mind that when we use aspirin, and if you see here, I've put these numbers in front of all of these. So 1 and 2 here means that aspirin blocks cyclooxygenase 1 and cyclooxygenase 2. Similarly, ibuprofen blocks cyclooxygenase 1 and 2, and so indomethacin does that too. Celecoxib is a selective cyclooxygenase 2 blocker. Rofecoxib is also a selective cyclooxygenase 2 blocker. So we had lots of hopes with the cyclooxygenase 2 blockers. However, their negative effects, their side effects on or adverse effects on cardiovascular system are so that we are kind of staying away from them nowadays. Okay, continuing. Let's look at how aspirin works. So very fascinating mechanism of action. So these blue guys here, these guys, these enzymes, for me, all of these things are guys. So guys or gals, don't mind. So these cyclooxygenases are usually found in dimers. What does that mean? The two of them are found together. And if you see, they are also in the cell membrane. If this was a cell and these blue ones are the cell membranes, the cyclooxygenases are embedded in the cell membranes here. Cyclooxygenases have a channel in them that allows various things to go in. So for now, what is important for us to realize is that arachidonic acid will go into the cyclooxygenase. Cyclooxygenase has a catalytic site, or a site where it works on the arachidonic acid. It's an enzyme. So arachidonic acid goes in, attaches to the catalytic site. Catalytic site changes the arachidonic acid to PGH2. So that is what is released, and then we know that from PGH2, thromboxane A2 or prostacyclin and other products are made. So if it is a platelet, this will be thromboxane A2. And we talked about the platelet's thromboxane A2 function yesterday. Remember that we said that here, when we have the thromboxane A2 available in a platelet, or let's start from here. The resting platelet has PGI2 acting on it, which causes the calcium to be ejected from the resting platelet because there is more cyclic AMP produced. And then the the thromboxane A2, on the other hand, does the reverse of that. What it does is it kind of starts the platelet activation, which means less cyclic AMP is produced, which means more ADP and ATP is produced, which then causes the calcium channel here to be blocked. We talked about it yesterday. So anyone who had not watched the lecture yesterday, that was the epoprostenol lecture. So calcium channel is blocked. That causes more ADP and ATP. That causes more calcium to be accumulated in the platelet, which causes the platelet to become active. That means platelet would have these spicules, and platelet would swell up like a angry hen, and it would start hugging the other platelets around, and then they would all shrink and kind of contract the platelet plug. So that is a mechanism we discussed yesterday. Going back here to the cyclooxygenases now. Cyclooxygenases will help produce thromboxane A2, for example. Now here is how the acetyl salicylic acid works, or aspirin works. So if you look at this diagram here, this thing is the acetyl salicylic acid. In here, this red part is the acetyl part. This remaining part is the salicylic acid. What happens is this substance, this drug, goes into the same place in the cyclooxygenases where arachidonic acid goes. And then in there, it connects to a serine molecule there, or a serine amino acid there. And that amino acid is present at the 529 place. So anyways, there is a amino acid in there to which the acetyl part, so if I zoom in here, do you see this part? This is the acetyl part of the acetyl salicylic acid. So imagine that acetyl salicylic acid comes in, leaves the acetyl part in there, and the remaining salicylic acid comes out. It has left the acetyl part in there. This is just like, for contraception, there are IUDs, or intrauterine devices. So imagine if this little cyclooxygenase is a small uterine device, uterus, then this acetyl part is like an intrauterine device. Now what happens is When the cyclooxygenase has the acetyl in it, then the arachidonic acid cannot come in because the internal part, the active part, is already occupied, or there is a substance already present there. And that causes the stoppage of arachidonic acid to be converted to thromboxane A2 or prostacyclin. So that is a function of aspirin. Now, what is the result of this function? So look here, this is a very interesting thing. Look at two characters in this diagram. One is the platelet here. We know that platelets make thromboxane A2. Thromboxane A2 is what activates them. Similarly, the endothelial cells, the cells of the blood vessels, they make PGI2 or prostacyclin. We talked about that yesterday. Now, prostacyclin causes platelet inhibition, platelet aggregation inhibition, right? They stop the thrombus formation. On the other hand, the thromboxane A2 causes the thrombus formation. Now, when you give aspirin, so here is the aspirin, and here is the aspirin. When you administer aspirin to a person, what happens is that the aspirin will, when it would act on the platelet, it would cause, let me just take the caption off so that we can see the whole screen. So when we administer aspirin to the platelet, platelet would form less thromboxane A2. And so here, if you see, this platelet is crying and he is disabled. Why is he disabled? Because platelets do not have a nucleus. When you give aspirin, and aspirin goes in a platelet and causes the enzyme cyclooxygenase 1 and 2 to be inhibited, platelet does not have a nucleus to make new COX enzymes. So this platelet is now disabled for its life. That is why you're seeing this platelet standing here and kind of crying. Once the platelet is disabled, that means it will not aggregate anymore. That means it would not make thrombi anymore. On the other hand, look at this cell, the endothelial cell. It is a nucleated cell. It has a nucleus in it. So when you give aspirin, it would actually go onto the endothelial cell as well and cause the cyclooxygenases to become disabled over there as well. However, because the cell has a nucleus of its own, that nucleus in a few hours to days will make cyclooxygenases again. What does that mean? So that's a very, very important thing to keep in mind. That means the endothelial cells will continue to produce prostacyclins, which are antithrombotic, while the platelets cannot make thromboxane A2, which are prothrombotic. So what have we done in the body? We have reduced clotting by two mechanisms. One, by disabling the platelets, and secondly, we temporarily disabled the endothelial cells, but they became enabled again for their production of the PGI2s, and they have started releasing the PGI2, which further inhibits the platelets. Now, sometimes people talk with me and say that means aspirin would be very dangerous because if you give it, then the person doesn't have thrombus formation capability for 10-12 days. That is not entirely true. Yes, the platelets that were present at the time of the aspirin administration, they would become less active. However, our body is creating platelets all the time as well. So aspirin is not a very, very strong antithrombotic. It is a mild antithrombotic, it does a mild control on hypercoagulable state. So that is why it is used in Math Plus protocol in the early parts of the disease. So aspirin is very, 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 very important. So there's a comment by Abdur Razak. It means aspirin is very important. Yes, it is very important because it would allow the platelets not to aggregate. So far so clear? Do we understand that how aspirin causes the cyclooxygenases to be disabled? Secondly, do we understand that it actually causes that disability in platelets and endothelial cells, but platelet cannot recover from this situation, so they are disabled forever till their life. Their life is 10 to 12 days. After that, they die. But the endothelial cells can produce more cyclooxygenases because they have nucleus, so they would recover from the effect of aspirin within a few hours or a day. Good. Now let's look at other effects of aspirin as well, which are actually, some of these are useful in COVID-19. The top one is anti-inflammatory effect. Anti-inflammatory effect is that aspirin can actually work with the tissue kallikrein system. Tissue kallikrein system is a system that are proteins which are revealed or brought out when the tissue is damaged. These damaged products, indicators, then cause the inflammation to occur. We know this now, I think, very, very clearly, that when a tissue damages because of viral infection or bacterial infection or other reasons that the tissue is broken down, that causes the tissue damage products to be released. So the kallikrein system is interfered with. So the tissue is not allowed, because of aspirin, to release a lot of damaged products. And the result is that the inflammatory system, that is the granulocytes, that, remember that we talked about it, that in the blood vessels, the inflammatory cells would come in, they would adhere to the blood vessel, then they would come out of the blood vessel, and then they would fight at the place where there is infection. So this adherence of an immune cell to the blood vessel is hindered by aspirin. Similarly, the chemotaxis, that is movement of the immune cells to the area of infection, is called chemotaxis, the walking of them, these cells. And the chemotaxis of polymorphonuclear cells, that is neutrophils, and macrophages, is also hindered by aspirin. So imagine how important this is at this time for COVID-19 or any other inflammation, because not only aspirin is going to reduce the thrombus formation, but it is also going to reduce the inflammation and the fight that is going on. Most of the damage in COVID-19 is not just by the virus, but it is by the inflammatory system and the fight that happens. So anti-inflammatory effect is very interesting. Then analgesic, that is, it acts as a painkiller. So how does it do that? Number one, when it reduces inflammation, so of course, inflammation, when it is reduced, would automatically reduce pain in that area. Secondly, aspirin can actually work on the brain, subcortical areas, that is the thalamus area, and it can actually suppress the feeling of pain in there. So that is how it takes care of the pain. Then it is anti-pyretic as well, that is, it takes care of the fever. And how does it do that? It goes in the central nervous system and suppresses the cyclooxygenases over there as well, which causes less arachidonic acid and leukotrienes and prostaglandins to be formed, which also reduces the pain, the fever, and more importantly, interleukin-1 release. Remember, interleukin-1 is released from macrophages when they are eating up viruses and bacteria. So when the interleukin-1 production is reduced, that reduces fever, because it is interleukin-1 that goes to the brain and then causes the hypothalamic fever system or the temperature controller to become disrupted, and that is what causes the fever. So aspirin helps reduce interleukin-1. Then I think most of us know that aspirin is recommended to patients who may have a previous infarction, heart attack, and we administer them aspirin for lifelong, a baby aspirin, a small dose of aspirin, and that is the MI prophylaxis. So you are trying to prevent the next heart attack by giving them aspirin. So it reduces the risk of death in these patients, and it reduces the risk of non-fatal myocardial infarctions. Finally, aspirin is also interesting for preventing the risk of, reducing the risk of strokes. So once again, transient ischemic attacks and strokes in men. Interestingly, it has not seen to do this in women, but in men who are prone to ischemic brain injury, to them, aspirin seems to have very positive effect and reduces the risk of stroke and TIA. So in here, from COVID-19 point of view, what is very interesting for us is, number one, anti-inflammatory effect, and number two, its effect on reducing the thrombus formation by this mechanism. Good so far? So I'm going to talk about, there is a comment that what dose do you recommend daily? So I'm going to talk about the doses right now. Normally, the daily dose is anywhere from 70 to 80 milligram, which is the baby aspirin. So now let's talk about some of the bad things that aspirin can do. So let me explain why some of these things can happen. Look here, we talked about it that aspirin would block this pathway, right? It blocks cyclooxygenase 1 and 2, which causes blockade of this, which causes blockade of all of these. However, when these things are blocked, what will happen is that there is a lot of arachidonic acid present. Now, what do you think arachidonic acid will start making? It will balance towards lipooxygenases and start making leukotrienes. Now, when the person has more leukotrienes, then the person can have more allergic reactions. So you would see that some of the side effects of the aspirin are because of the balance of arachidonic acid moving from some to this side and some to this side, moving from that to majority of the arachidonic acid being used in lipooxygenase pathway. And that causes the allergies. So back here now, one important thing is the Ray's syndrome. Ray's syndrome normally occurs in the younger children. The exact mechanism and cause is not known. However, in case of aspirin, here is what happens. Aspirin, when it is used in a cell here, this was the aspirin, acetyl salicylic acid. When it went into the COX enzyme, when it came out, the part that came out was salicylic acid, and the acetyl part was left in the COX, right? This salicylic acid enters blood, and where from the blood it comes in and goes into the liver. Liver's job is to take this and further metabolize it to make it excreted in the urine. In that process, the salicylic acid starts accumulating in the liver if it is in higher amounts, or if the person also have a viral infection, or if the person has a predisposition towards Ray's syndrome. In all those cases, the salicylic acid that is now aggregating or accumulating in the hepatic cells, over there it kind of disrupts the lipid metabolization of in the hepatic cells. So lipids are not metabolized anymore. The result of that is that liver cannot make enough ATP. So that is one issue, that now the person has low energy levels. Secondly, the liver has now accumulation of lipids in it, which would cause steatosis. Steatosis means the accumulation of the lipids in the liver. Thirdly, because of low ATP and because of lipid accumulation, the liver function will be disrupted. And when the liver function is disrupted, one very important part of that is ammonia conversion. So ammonia is produced in our gut by bacteria. That ammonia is absorbed in our blood. From the blood, it goes to liver. In the liver, it is neutralized. If we do not neutralize ammonia correctly, then that ammonia is going to go into the brain. Once it goes in the brain, it can, in the small doses, it can cause sleepiness, drowsiness, and just kind of disorientation. But in larger doses, as happens in hepatitis patients or liver cirrhosis patients, in larger doses, that ammonia can actually cause brain damage and cause coma, seizures, and death. So because of this, people who are predisposed for Ray's syndrome, especially smaller children, should not use aspirin. Now the question is, who are predisposed to that? It is not exactly known, but a general thing is that if somebody has nasal polyps, they are also prone to developing Ray's syndrome. What is the mechanism? It's not known. Maybe nasal polyps is an indication of predisposition to allergies, and because aspirin can cause the leukotriene balance to become more active, because arachidonic acid is becoming more leukotrienes now, maybe that is the reason, but it's not exactly clear. Now, other side effects in various doses. So first of all, in therapeutic dose, that is a dose that we give for example, in COVID-19, or therapeutic dose for managing the fever or pain or inflammation. In those doses, if it is given on a continuous basis, what it does is this. There are, in our stomach, we have goblet cells. These goblet cells, their function is to produce mucus. That mucus protects our stomach's surfaces from acids. So that mucus is kind of protective. Aspirin causes these goblet cells to malfunction, and they reduce their production of mucus. When mucus production is reduced in the stomach, that means protective lining is reduced and the stomach can easily become damaged by its own acids. Second thing what it does is it acts on the other cells that are called parietal cells and it upregulates them. That causes these cells to produce more acids. And of course, now if you take the protective layer down and if you create more acids, you are going to cause stomach damage. So that is the aspirin's reason for creating ulcers in therapeutic doses. In higher doses, the person can actually experience something called salicylism. And salicylism is where there is vomiting, tinnitus, reduced hearing, and vertigo. Fortunately, this all is reversible. So you stop the aspirin and this can be reversed. In very large doses, so here, this is a very important concept to please see. It causes hypernia. What does that mean is that patient has or the person has deep breath and more in number. So they have deep, rapid breathing. That causes a lot of carbon dioxide to be thrown out of the body very quickly, which then causes respiratory alkalosis. I think that's a physiological mechanism. It would take time to explain that. But generally what happens is when you wash out too much carbon dioxide, then the alkalosis would occur in the body. Then with that, severe hypothermia can occur. And this is because of decoupling action of aspirin, and I'm going to explain that in a second here. But think about it for a second. Aspirin is given to reduce fever. But if you are giving it in larger doses, it can paradoxically cause fever. So let's see what causes that. I hope you remember this diagram from our CoQ10 discussion. This is a mitochondria. Now what happens is, remember in the mitochondria, we have electron chain that causes the electrons to move from one complex to the other complex to the other complex, finally to the ATP synthase, which will then convert. So over here in the last complex, the electrons are combined with oxygen and we make water. So that is fine. But remember, we talked about it, during this whole process, protons are moved from inside of the matrix of the mitochondria to the intermembranous space. Or you can just say that they are brought out of their home. So when they are dragged out of their home, they want to go back in. And how do they go back in? They enter this ATP synthase, this blue guy over here, this enzyme. They enter it, and with the concentration gradient, they try to force their way back into their home, and that causes this motor to rotate, and that causes ATP to be produced. However, the aspirin is so bad. What it does is, see here, it is in love with hydrogen. So it takes hydrogen and gives it a ride back in the matrix without it having to go through the ATP synthase. So now think about it. What is happening now? Our body is, we are eating food, we have oxygen, we are using that to finally make ATP, and aspirin is present in large dose, and those hydrogen that we have brought out so that they can drive the ATP synthase to make ATP, aspirin is just picking them up and bringing them back in. That silly aspirin is just disrupting the whole thing. We have eaten food, we have done so much. We've taken breath. We have brought all of that in the cells. We have brought all of those components in the mitochondria to ask the mitochondria to make ATP for us. And the silly aspirin is sitting over there and just taking those hydrogens and saying, hey, I'm your friend. I can bring you back in the matrix without any cost. The result of that is our ATP production goes down because the ATP synthase is not functioning anymore because hydrogens are not available to it. The second thing is that this chain now has become decoupled from ATP synthase, and lots of enzymes are coming in. Aspirin is just taking protons and pushing them back in, and this chain is running like crazy because it is trying to produce ATP, and there is no ATP because aspirin is short-circuiting the whole thing. When that chain runs so crazy, that creates heat, and that is what causes the heat or hyperthermia in large doses of aspirin. Very dangerous. This actually can lead to death. And then finally, in still larger doses, the same function that I showed you here, these mechanisms become even more exaggerated. Alkalosis becomes even more exaggerated, which then results into compensatory acidosis, which also results into potassium exchange with hydrogen, which causes hyperkalemia, which then also makes acidic urine, and the whole acid-base imbalance in the body with hyperthermia causes the CNS damage and CVS damage, and heart attack or brain damage occurs and the person can die. So this is what happens with very large doses of aspirin. Normally in therapeutic doses, it is really 40 milligram or 80 milligram is taken, low dose, and then larger doses are given if needed in the hospitals. That should not be taken by anyone. And finally, stopping here, I'm going to just quickly show you this trial. This is the lead COVID-19 trial, low risk early aspirin and vitamin D to reduce COVID-19 hospitalization. Here, their basic theory is that vitamin D is necessary to prevent the acute respiratory distress or pneumonia because of COVID-19. And in addition to vitamin D, they're also providing aspirin as a antithrombotic right from the beginning to see that patient does not progress to hypercoagulable state. So with this, that is the discussion today. I hope you enjoyed it. Aspirin is a fun substance. It is very important as well. We use that on a daily basis. It helps with inflammation. It helps with the fever. It helps with pain. And it also helps with the platelet aggregation blocking. So it is, you can call it a mild thrombolytic, or antithrombotic effect. So this is what we have. I am still working on the case to present. So hopefully next week I will present that. Tomorrow we'll continue with the next drug in the Math Plus protocol that we have not discussed before. If you would like to have any other topic as well, please share and comment, and we'll go from there. I hope this was fun, and I hope that you're all staying safe. Talk to you tomorrow. Thank you very much.